common topics for all of us. We do cataract surgeries and tend to have complications. One of the most feared complication will be a posterior capsular tear. And if you see your patients carefully, you know the risk factors, which is highlighted here in various types of cases. Surgical technique-wise also will make a huge difference. But there are certain stages of your surgery, steps of your surgery where posterior capsular opening can be much more fearsome, like towards the end of your nucleus emulsification, or especially when you are doing your irrigation aspiration. In experienced hands, normally it happens during the end of surgery because your nucleotomy, you take full care, and when you go for IA, you have complications. But it can happen during IOL insertion, hydration of wound also, especially posterior capsular weakness. So I would think the proper examination of your patient is very, very important to begin with. If you see these type of patients, you can see this is a typical posterior polar cataract, will have higher chances of rupture of posterior capsule. And this is a patient who already have a pre-existing posterior capsular defect. So these examinations will help you how you're going to convert your surgery on the table and modify your technique so that you safeguard the posterior capsular tear. Other would be the hardness of nucleus will also make pretty difficult sometimes. You have a brown cataract, black cataract, or a white intumescent cataract. You can't see what is there in the posterior capsule. In such cases, you can have a difficulty. So I would always suggest just don't see the eye you're going to operate at that time. Always see the other eye also. There's a telltale sign in the other eye also, poor pseudophakia, ACIOL, aphakic eyes, bullous keratopathy. That will give you some sort of a clue that this surgery in this eye can be difficult. But if I can access the anterior segment OCT for all my patients, I like to see the posterior capsule before I take them for a surgery. So this is my anterior segment OCT. You can see this is a thick plaque in the posterior side, but my posterior capsule is absolutely clear. So this patient is going to have a lesser chance of posterior capsular dehiscence. So this is another case. You can see here, I can delineate the posterior capsule correct here, but this area, the posterior capsule is not delineated, or a posterior plaque is quite adherent to the posterior capsule. So this patient, you need to do a good hydrodissection before you go for a manipulation inside. So you can see this is patient where I can't see the posterior capsule at all. So this patient again require a careful dissection for such patients. So this is a patient already has a posterior capsular tear. The bulge, which is, you can see a convexity towards the vitreous cavity, tells you that there's a PC defect. The pre-op examination tells you what type of case you're handling with. But if you have access to intraoperative microscope, which has an OCT, again, I can delineate my posterior capsule clearly. And I can also access, after I've done a hydrodissection, what is the posterior capsule at the end of my hydrodissection. You can see here the clear space between nucleus and epicortex and the posterior capsule. So I've got a good delineation, and I've got a good hydrodissection also, and PC is clear. So my surgery is going to be simple here. If I do some sort of a wrong technique, maybe posterior capsule will get dehiscent. Otherwise, this surgery should go quite okay. So these are various signs you all know: sudden deepening, clear red reflex, inability to rotate, difficult flowability. All these things are, and what all steps we're going to take in these cases is important here. So I have some video collections, mine as well as our trainee videos, just to show one typical sign, pupillary sniff off sign. You can see here, one of my trainees doing a hydrodissection. The mistake here is he's doing from the side port. So always when you do hydrodissection, make sure you do it from the main port. The viscoelastic will come out easily and pressurization will be less. See how much viscoelastic is coming out from the side port here. And just see the pupil is now 8 millimeter and trying to do a hydrodissection. And just see what happens when he does injecting. Sudden constriction of pupil, and this suggests that posterior capsule are given way. So this is the one important sign to begin with, and you have to decide at this stage you are going to continue phaco or you want to shift to other type of surgery. But if you have access to a OCT, that will give you something clear. Other important thing is you should preserve the posterior capsule nucleus support till the end, so that you have a posterior capsule. Over that, you have an epinucleus here. So this is, I'm doing a nuclear emulsification at this stage. You can see here, this particular area, I'm taking this piece, making smaller area, emulsifying this. Suddenly I can see this is the area where I have no support of epinucleus. So that area is going to be tricky for you. It might open up any time. So what we are going to do towards the end of emulsification, because the posterior capsule is very nearer to the handpiece because the pieces are less. I'm going to inject dispersive viscoelastic at this stage, remove my second instrument, that is chopper, and then inject the dispersive viscoelastic. See here, this is a clear opening here. So this has to be prevented from a rupture. So that is very important to assess here. See here what I'm doing, I'm injecting dispersive viscoelastic here. This will tamponade this area and safeguard the posterior capsule. Subsequently, you can clearly emulsify the nucleus and make sure you have a comfortable time. Keep injecting dispersive viscoelastic instead of using chopper, and you can complete the phaco very easily without damaging the posterior capsule as such. This is again one of our trainee videos here, showing the difficulties he's facing with the nucleus emulsification and chopping here. And you can see here the chopping, the rotation is happening very nicely. Suddenly that nucleus would have a difficult rotation as well as the tilt which is happening. See how difficult the chopping is, and there's a definite tilt happening in the nucleus. So once you have a space which is not equal either side, that means there's either dialysis or there's a large posterior capsular tear. You can see the entire nucleus is tilted up. So this is a time you have to take a decision to convert to extracapsular surgery and go away with this. So sometimes you can have a case like this. Again, a trainee video here. You can see, you can already see a space here, which may be a case of posterior capsular tear to begin with. So what the surgeon is trying to see if the nucleus can be rotated here. And he thought maybe he can rotate and do a emulsification here. But I'm pretty sure there's a vitreous in this particular area. As you go with the handpiece, you put on your fluid, the nucleus will drop out into the vitreous cavity, drop in. So that should not happen. You could have done a pars plana infusion at this time and retrieved the entire nucleus and completed the surgery. Now this requires a BR surgery subsequently. So this is one of my patients where I was doing a nucleus in a grade 4 nucleus, emulsification going quite all right. You can see almost half the piece is taken away. And once I reach this stage, rotate this nucleus to a comfortable area. I'll do emulsification at that time. You can see clearly it's been done. Now I'm left with 1/3 of my piece. I thought I'll just pull this nucleus because rotation was a little tough. Away side, you can see how the nucleus rotates backwards and my handpiece touches the posterior capsule. So sometimes if you have a larger piece, don't try to flip it. Always rotate to the axis where you can do a good emulsification and safeguard the posterior capsule. If you remember my second video where I had prevented the open posterior capsule by viscoelastic, that is important here. But I have dispersive viscoelastic here. I'll inject it, safeguard the posterior capsule opening, tamponading, then put a 3-piece IOL onto the rhexis, then take away these pieces onto the IOL. So this is the IOL scaffold technique popularized by Dr. Amar as such. But many people do it comfortably. You can see the pieces here, and you can emulsify subsequently without increasing the posterior capsular area. So I'll just show one more video where a PC tear can happen in a posterior polar cataract despite doing a femtosecond application. Comfortably, I have done a nucleus emulsification. I'm at the stage of aspiration here. Most posterior capsular plaques will open up during the aspiration. You can see the tear has already visible here. And normally it is an elliptical tear in the center. If you don't manage at this stage, it will go through limbus to limbus and things will be difficult. So what I am doing, I'm injecting dispersive viscoelastic and converting this small tear to primary posterior capsular rhexis. Subsequent surgery is effective. The idea to show this video was to pick up the tear early so that it doesn't enlarge further and you can safely do a surgery subsequently with implantation. The post-op, you have to see all these cases to look for a posterior segment problems. Always look for other risk factors for your patients. And most important thing which we see in a PC tear is when you can't implant PCIOL, there'll be an increased incidence of floaters, detachment, CME, secondary glaucoma, endophthalmitis, and PBK. Very, very significantly, diabetic retinopathy might increase. But most importantly, if you have not counseled your patient appropriately, you can have a very difficult time for yourself also. To summarize, do not panic. Look for evidence of PCR in early stage of your surgery so that you can prevent further complications. And always take care of your vitreous, which is going to be a major problem for a PCR patients. If there's no vitreous prolapse, things are all right. If vitreous prolapse, Make sure you see bitters clearly, remove clearly, and maintain the cornea clearly for subsequently. Thank you for your kind listening. Any questions which